today I am discussing about approach to evaluation of Cushing's syndrome. My moderator is Dr. Sarma sir. Coming to the introduction, Cushing's syndrome reflects a constellation of clinical features that result from chronic exposure to excess glucocorticoids of any etiology. The disorder can be ACTH dependent, ACTH independent, or iatrogenic. The term Cushing disease refers specifically to Cushing's syndrome caused by a pituitary corticotrope adenoma.
1 second here, hold on. Now, when we are, as you present, I am going to discuss. That is why I am asking you to stop after every slide. Okay. See, there are disorders of cortisone excess and cortisone deficiency, cortisol excess and cortisol deficiency. Today we are going to look at the cortisol excess, how to evaluate the cortisol excess. So this is called CD or CS. Cushing's syndrome is it has got a very typical features which we are going to discuss now. It can be two types. One, ACTH dependent, and the other one is ACTH independent. That means there is excess ACTH and that is causing the excess cortisol. The other way around, ACTH is normal or suppressed because of excess cortisol from the periphery, that is from the adrenal cortex, probably due to adenoma or a cancer or some other disease within the adrenal gland. We generally call these in thyroid disorders as primary and secondary. Primary and secondary means primarily the thyroid disorder, secondary to pituitary disorder. Here also, primarily adrenal disorder is ACTH independent. Dependent on the pituitary is called the ACTH dependent. This ACTH may come from the pituitary or may come from any other extra pituitary source. In such a case, it is called ectopic ACTH Cushing's. Okay. Now, how many things we have? One, pituitary related ACTH excess causing the excess cortisol. That is one. Two, non-pituitary, some other tumor producing ACTH, ectopic ACTH. And the third one is nothing to do with the pituitary, but the adrenal gland is at fault. Adrenal hyperfunction per se. This is called the primary or adrenal hyperfunction due to various causes. Okay. So when you say Cushing's disease, it automatically means it is caused by the pituitary. Okay. Pituitary, when we say CD, it means that. Whereas CS encompasses these two other things. Okay. Did you understand that very clearly?
Yes, sir.
Now let us go to the next one.
Hypothalamic pituitary adrenal axis. Whenever there is a endogenous or exogenous stress, the hypothalamus releases a corticotropin releasing hormone, which in turn stimulates the anterior pituitary, and it cleaves the 241 amino acid called as pro-opiomelanocortin to 39 amino acid called as ACTH, and the ACTH in turn stimulates the adrenal cortex and releases the cortisol. These cortisol in turn after the effective function, the cortisol inhibits the negative feedback to both the hypothalamus and anterior pituitary.
Very good. A diagram from the Harrison. Good that you have looked at Harrison also. Now, ACTH adrenal cortex is secreting cortisol. This cortisol feedback inhibition to anterior pituitary and feedback inhibition to hypothalamus. So hypothalamus inhibition reduces CRH and anterior pituitary hormone reduces ACTH and cortisol is for production is stopped. The other way around, when there is stress or physical or emotional, including fever, hypoglycemia, hypotension, and normally this is physiologically itself, there will be neurotransmitters which of the stress which act on the hypothalamus, produce excess CRH. CRH stimulates the anterior pituitary to produce ACTH, which stimulates the adrenal cortex to produce cortisol. Okay, GFR. Zona glomerulosa, fasciculata, reticularis. Glomerulosa mineralocorticoid. This is glucocorticoid, and this is androgens and estrogens. So in the alphabetical order, M, G, A, G, F, R, mineralo, gluco, andro. Remember like that for the convenience, isn't it? Okay, let's go ahead.
This diagram here depicts the physiological cortisol circadian rhythm. Normally, the cortisol levels are more during the early hours and peaks during the morning hours, that is 8:30 a.m. And a peak will be seen in afternoon hours, and it will be low in the midnight or during night time.
That is very important. Unlike other hormones which are secreted almost uniformly in the blood, except insulin, there is basal secretion, there is postprandial secretion. Like that, here there is a circadian rhythm, that is 24-hour variation in the cortisol. It could be as low as this much in the night, around midnight, 12 o'clock or something like that, or as high as this much around 8 a.m. So 525 micrograms to 145 nanomillimoles. 525 is 145 nanomillimoles. That is the basal level. And this is acrophase at around 8:30. That is the acrophase. So this is important to know. The adrenal dysfunction can be two types, as he will present in the subsequent slides. Loss of the circadian nature and excess ACTH, with the result excess cortisol. Okay, now
coming to the causes of Cushing's syndrome. Cushing's syndrome may be ACTH dependent Cushing or ACTH independent Cushing. Out of it, 90% is ACTH dependent Cushing's. In ACTH dependent Cushing, most common cause is Cushing's disease, that is ACTH producing pituitary adenoma. And second cause is ectopic ACTH syndrome due to bronchial or pancreatic carcinoid tumors, small cell lung cancer, medullary thyroid carcinoma, pheochromocytoma. And the ACTH independent Cushing's causes are adenocortical adenoma, adenocortical carcinoma, and rare causes like macronodular adrenal hyperplasia and primary pigmented nodular adrenal disease and McCune-Albright syndrome.
Now, these are relatively few in number. As we can see here, 10% of the Cushing's syndrome is due to ACTH independent. That means adrenal gland by itself is hyperfunctioning without the knowledge of the pituitary or the hypothalamus. Then what will happen? Compensatorily, there will be feedback suppression of CRH and ACTH. If you measure ACTH levels in these people, ACTH will be subnormal, less than 5. Whereas in case where ACTH is the cause and more ACTH is generated due to either CRH or ACTH from the anterior pituitary, then Cushing's disease, which is the commonest, 90% are from above, and 10% are periphery, that is the adrenal cortex. Out of the 90%, 75% are pituitary, 15% are ectopic. What are the ectopic sites? Bronchial carcinoma, pancreatic carcinoma, small cell lung cancer, medullary thyroid, pheochromocytoma, and many other ectopic ACTH syndromes. This could be a short notes for you. Ectopic ACTH syndrome can be a short notes. And look at this, the male-female distribution. If it is from the pituitary, it is 4:1. If it is from the adrenal gland per se, it is 4:1. But if it is ectopic, there is no sex discrimination. It will be 1:1. Whereas if you have independent adrenal primary disease, majority of them are adrenal adenoma, which is benign and can be knocked off. Very small proportion is adrenal carcinoma, and less than 1% are the other diseases. You may not know about these diseases because you are not an endocrinologist. You won't get to see any patient here. What all you get to see is mostly these fellows or those fellows at the most adrenal per se hyperfunction, particularly adrenal adenomas you get. This is what you have to get into. Yeah, here I have got two types of Cushing's. One is ACTH dependent, which is secondary to excess ACTH from above. It can be from the pituitary, in which case it is called Cushing's disease. It could be from ectopic sources, as listed here. The pituitary origin is the commonest. 75% of them belong to that. 15% belong to ectopic ACTH. Total 90%. What about the 10%? These 10% remaining are primarily from the adrenal gland, which is the most common cause. A benign adenoma is the most common cause. Carcinoma, only 1%. Other rarer causes, less than 1%. Okay?
Okay.
Come.
Coming to the signs and symptoms, body fat like weight gain, central obesity, moon-like faces, and buffalo hump. In skin, it causes facial plethora, thin and brittle skin, easy bruising, and broad and purple stretch marks, acne and hirsutism. Bone, it causes osteopenia, osteoporosis, and in children, there is a decreased linear growth, and in muscle, it causes proximal myopathy. In cardiovascular system, it causes hypertension, hypokalemia, edema, and atherosclerosis due to excess mineralocorticoid effect. And metabolic disorders like glucose intolerance, diabetes, and dyslipidemia. In reproductive system, it causes decreased libido in women and amenorrhea. And central nervous system, it causes irritability, emotional liability, depression. Blood and immune system, there is an increased susceptibility to infections, and there is a risk of deep vein thrombosis and pulmonary embolism. Here, the body fat, skin, and bone and muscle are discriminatory features of Cushing's syndrome, whereas cardiovascular and metabolic and reproductive system are non-discriminatory features of Cushing's.
Very good. Very nicely presented this slide. It is a self-explanatory slide. What is more important is majority of the obesities can be confused with Cushing's syndrome. And then skin changes are very specific. Bone changes are also very specific. Proximal muscle weakness is very important. Of course, these are non-discriminatory things, and reproductive features, and also central nervous system features, and immune-mediated features. Very nicely taken from Harrison, very nice table. It in a way gives a very quick look at what are all the various things that can happen, clinical signs and symptoms in Cushing's syndrome. Okay.
Coming to the diagnosis of Cushing's, it is a stepwise approach. First is the clinical suspicion and screening for hypercortisolism. And second thing is establishing the endogenous hypercortisolism. Third is determining the source of endogenous hypercortisolism, that is ACH dependent versus independent Cushing's syndrome. Followed by ACH. In the ACH dependent, we have to differentiate from Cushing disease versus ectopic Cushing's syndrome, and in ACH independent Cushing's syndrome of different etiologies.
Very correct. Now, the first and foremost thing that we have to demonstrate is when we have a clinical suspicion of Cushing's syndrome, does he or she has hypercortisolism? Can I demonstrate excess cortisol in the blood? If the excess cortisol is there, then endogenous hypercortisolism means not supplemented from outside. The commonest cause of hypercortisolism is iatrogenic. When we treat them for rheumatoid arthritis, psoriasis, or other skin conditions, or other autoimmune diseases, we prescribe steroids for a short while. People will go on taking it for a long time without our knowledge. They repeat the prescription. I had one patient who had rheumatoid arthritis. I prescribed him for 15 days some steroid, prednisolone 10 milligrams 3 times, and then he continued for 15 years without my knowledge. And he landed up with Cushing's syndrome, final renal failure, and he died. See how bad it can be. So most important is first thing in the history. If you suspect hypercorticism, what is the drug history? Is he taking iatrogenic or excess steroid from outside? That is excluded. Then that is endogenous hypercorticism. That is within the body itself, the cortisol is more. Where can it be? Is it coming from the ACTH or is it coming directly from the adrenal? That means is it ACTH dependent or independent? That will be the next question. If it is ACTH dependent, is the ACTH coming from the pituitary, that is Cushing's disease, or from an ectopic source, where you have to evaluate for the chest and other organs for any malignancy. And finally, if it is not from the pituitary, not ectopic, it must be from the adrenal gland itself, adrenal cortex itself. And that has a differential diagnosis: adenoma, carcinoma, and other causes, miscellaneous causes. This is the most common cause, is adenoma. So stepwise approach: is there evidence of hypercorticolism, cortisolism? If it is there any history of exogenous administration? That you write as the second line. The third line is establish it as endogenous. Then is it ACTH excess that is causing, or non-ACTH dependent? If it is ACTH excess, is it from the pituitary or is it from the ectopic source? If it is independent of ACTH, adrenal is culprit, then I have to do imaging of the adrenal gland to find out the etiology.
Step 1 is clinical suspicion and screening for hypercortisolism. Clinical manifestations of hypercortisolism are the result of an altered rhythm, that is quality, and excess cortisol load, that is quantum. Hypercortisolism has a broad spectrum of manifestation. Overt Cushing syndrome is easily recognizable, but it is difficult to delineate subclinical Cushing syndrome from the patients attending obesity, diabetes, and hypertension outpatient clinics.
Yeah. So the index of suspicion in Cushing syndrome should be very high, because it mimics obesity, it mimics metabolic syndrome, it mimics people with obesity and diabetes and hypertension. You mistake them unnecessarily and start treating them or evaluating them unnecessarily for Cushing's. So this is what is called the false positive diagnosis of hypercortisolism. Okay, and now the clinical manifestations of hypercortisolism should be established. These are because of two reasons. Is there a disturbance in the quality, that is the circadian rhythm, or in the quantity? Both can lead to Cushing's features. Okay.
Findings like visceral obesity, glucose intolerance, hypertension, and menstrual irregularities, though common in Cushing syndrome, are non-discriminatory. Specific manifestations of hypercortisolism are those affecting skin, that is livid striae and ecchymosis, in muscle, that is proximal myopathy, and bone, short stature in an obese child, and vertebral compression fractures. These catabolic manifestations are subtle in the early course of the disease and manifest with long-standing and/or intense hypercortisolism. Hypertrichosis over the forehead is a useful clinical clue.
Yeah. Now, what he is saying is this is not very useful because they are very common and non-discriminatory. What is very specific to Cushing's? Skin changes, livid striae and ecchymosis. We will see a picture of that, and proximal myopathy, and then short stature in an obese child. And I remember this, I have an experience when people presented young fellows with vertebral compression fracture. For some other reason they came for back pain. We looked at the vertebral compression fracture. When we evaluated ultimately, it landed into a pituitary-related Cushing's disease, which caused osteoporosis and vertebral compression fracture. This type of osteoporosis is called steroid-induced osteoporosis. Maybe exogenous sometimes, maybe endogenous also. Catabolic manifestations will occur only in a long-standing case. And of course, as you have said, hypertrichosis on the forehead is a useful clinical clue. How do you go about it?
Screening. The Endocrine Society guidelines recommend screening under the following circumstances. Patients with multiple progressive and discriminatory findings suggestive of Cushing syndrome. Cases with unusual features like hypertension or osteoporosis at the young age. Adrenal incidentalomas, and children with a decreasing height percentile and increasing weight.
Yeah. What are the people whom you suspect to screen? Not everybody can be screened. Just like you do blood sugar, you cannot evaluate for Cushing's in every person. There must be some clinical evidence like multiple system involvement, progressive disease, as we have seen in the previous slide, discriminatory findings like livid striae, like short stature, like osteoporosis, vertebral fractures. Particularly young fellows having hypertension or osteoporosis with fractures are immediately to be screened. That's what I told about one case we have detected like that. Incidentalomas are just do an abdominal scan for some other purpose. They report there is an adrenal adenoma. That is called incidentaloma. Incidentally found benign tumor. Sometimes it could be malignant also. We evaluate it. Adrenal incidentaloma. And of course, in children, the height is less, weight is more. That is decreasing height percentile with an increasing weight. One should suspect Cushing's in a child. Okay.
Supplemental Cushing syndrome is seen in 5 to 30% cases of adrenal incidentalomas, which in turn are found in 4 to 7% of adult population. Screening every diabetic patient for Cushing syndrome is not recommended, even though the prevalence of occult Cushing syndrome ranges from 1 to 10% in various series and often associated with very high false positivity.
Yeah. So what they are saying is, if somebody has a diabetes, don't start screening every diabetic for Cushing unless they have some reason to screen, like, vivid features, very discriminatory features, or they have an incidentaloma, or they have a vertebral compression fracture, or they have osteoporosis, hypertension, young age, then you can think of. Not that every diabetic patient needs to be screened.
Establishing endogenous hypercortisolism. Before establishing, we have to rule out history of exogenous glucocorticoid intake is imperative to rule out exogenous Cushing syndrome. In India, cases of exogenous Cushing syndrome are commonly encountered secondary to the ingestion of powder or injectable medication for pains and aches dispensed indiscriminately. Some features such as increased intraocular pressure, cataracts, benign intracranial hypertension, aseptic necrosis of femoral head, osteoporosis, and pancreatitis are commoner in iatrogenic than in endogenous Cushing syndrome.
It is beautiful statements that they have made. First of all, is the patient taking any exogenous corticosteroids? If that is the case, if you withdraw them, slowly taper them out, and then stop them and wait for 6 months, all the features will disappear. I used to have a patient by name Gomati, and she has a very big hump on the neck, on the back, below the neck, and then moon face, everything. When I went into the history, she said she is taking betnosol tablets, that is betamethasone, for over 15 years for her bronchial asthma. 15 years, and weight is around 85 kilograms. Then immediately we tapered the steroid, switched on to other modes of control of her asthma, and now she is 55 kilos. All that hump is lost. She looks so beautiful and young, and her husband complimented, "You made my wife 15 years younger." See, that is all because of exogenous glucocorticoid intake. Very common for bronchial asthma, rheumatoid arthritis, or other conditions. They keep on buying, in India, there is no regulation in the supply of these drugs. And anybody can ask for betnosol tablets or dexamethasone tablets or prednisolone, and they can get it. And they can take it for years because that is giving them some, so-called relief, but which is damaging inside, they don't understand. Okay, so this is the eye-opener for all of us. First of all, exclude exogenous intake. And how do I differentiate exogenous from endogenous? The last paragraph on the slide is illustrative. In case of intraocular pressure, cataract, benign intracranial hypertension, aseptic necrosis of the femoral head, osteoporosis, pancreatitis are the common iatrogenic causes. We had a boy around 15 years who had aseptic necrosis of the femoral head. So when we went into the history, the person was on steroids for a long-standing skin ailment, and that resulted in the aseptic necrosis of the femoral head. So these are all, the clinical medicine is so intriguing. Unless you have your mind on that, you will not be able to understand why a thing has occurred. Okay.
History of depression, severe obesity, or chronic alcoholism may suggest pseudo-Cushing syndrome. That is, it has reversible hypothalamic pituitary adrenal axis hyperactivity. Usually, such cases are clinically mild, may show suppressed cortisol with dexamethasone suppression test, and reverse to normal with treatment of an associated condition.
This is pseudo-Cushing's, means people with obesity, people with depression, alcoholism, they have some sort of HBA axis hyperactivity may be there, and that can easily be understood because the cases are very mild, and once they come back to normal, once you reverse to normal with treatment of the associated condition. Okay.
The test available for the quantitative estimation of cortisol load is 24-hour urine-free cortisol. And to assess the circadian rhythm and quality of HPA axis, it is midnight serum cortisol and late night salivary cortisol tests are useful. The suppressibility of the HPA axis is judged by the overnight dexamethasone suppression test and standard 2-day low-dose dexamethasone suppression test and low-dose dexamethasone suppression test with corticotropin releasing hormone stimulation test.
Yeah. So what are the tests available? For to diagnose thyroid disease, very easy. Do a TSH, you know, hyperfunction or hypofunction. At the most, you do a T3, T4, T3, T4. That's all. Here it is not like that. The first test we have to do probably is one among the first two lines: 24-hour urine-free cortisol or midnight serum cortisol at 12 p.m., 12 midnight, or late night salivary cortisol. How you do the test? It will be described in the later on section. If you have a suspicion one of these tests is positive, then you cannot confirm the diagnosis. You have to have a second test. And second test should not be the same one. You can repeat the test again, no problem. But you have to add an additional test like the ODS or overnight dexamethasone suppression test or a standard low-dose dexamethasone suppression test. Very rarely you may require LDDS or you can petrosal sinus sampling. You have to resort to at a later stage. So what is the message? If I want to know a patient is having hypercortisol features, is there exogenous steroid use? That is excluded. Then it is endogenous. What is the first step? Do 24-hour urine-free cortisol or midnight serum cortisol or late salivary night cortisol. If one of these tests is positive, follow with the other type of test which is listed in the second part of this slide, that is ODS or LDDS, and very rarely you may require corticotropin releasing hormone stimulation test along with the LDDS. Okay. Now he is describing here the various tests. How do you do those tests and how to apply those tests? You go ahead. Slowly I'll try to rather make it bigger.
Here it is summarizes all the tests with sensitivity. 24-hour urine-free cortisol, 2 samples must be obtained and sample collection should be complete and refrigerated until analyzed. Cut off the diagnosis, upper limit of the normal, more than 3 times you have to take. And its sensitivity is 90% and specificity is 96%. And late night salivary cortisol, 2 samples between 11 p.m. and 12 a.m. either by passive drooling or the salivate method. More than 1.45 nanograms per milliliter is sensitivity and take as positive. And its sensitivity is more than 90% and specificity is 92%. And sleeping midnight serum cortisol, prerequisites are indoor stay for 24 to 48 hours and pre-cannulation of the patient, and timing of sample collection is 12 a.m. or within 5 minutes of awakening. And that test positivity is taken as more than 1.8 micrograms per deciliter and its sensitivity is 100% and specificity is 20%. Overnight dexamethasone suppression test, oral dexamethasone of 1 mg at 11 p.m. and serum cortisol 8 a.m. next morning will be taken. And if serum cortisol level more than 1.8 micrograms per deciliter, it considered as positive and its sensitivity is more than 90% and specificity is more than 90%. And standard 2-day low dexamethasone suppression test, if weight is more than 40 kgs, we will take 0.5 mg every 6th hourly for 2 days and we obtain serum cortisol 6 hours after the last dose. If weight is less than 40 kgs, we will adjust the dose to 30 micrograms per kg per day. And test is considered positive if serum cortisol is more than 1.8 micrograms per deciliter. And low dose dexamethasone suppression with corticotropin releasing hormone. 2 hours after the last dose of dexamethasone, IV corticotropin releasing hormone is given at the rate of 1 microgram per kg is given, and serum cortisol is level done at 15 minutes later. And test is considered positive if it is more than 1.4 micrograms per deciliter. Here we have to remember that none of the test is as sensitive and specific. So we have to do at least 2 tests for confirmation.
Correct. Now, these tests can be divided into 2 levels. first line test and second line test. First line tests are these. These are the 1, 2, 3 are first line tests. What is that? 24-hour urine-free cortisol. Collect 24-hour urine. Cortisol is a product which will be destroyed by heat. So you have to refrigerate the sample. How do they do it? They collect it, put the can in the refrigerator. Again, when you go to the bathroom, take it out and again put the urine in that. Again, get back to the refrigerator. This is essential, a little cumbersome also. Any test which has got a sensitivity of 90% and specificity of 90% is accepted as a very good test. And here also, 24-hour urine cortisol, if it is 3 times the upper normal limit of the urine cortisol, then it is called positive. A positive test confirms the disease, is specific. Suppose it is less than 3 times upper normal limit, it rules out the disease. It is called negative test. Negative test means it is highly sensitive to rule out disease. A positive test, if it is more than upper limit of 3 times upper normal limit, it is a positive test. It confirms the disease. It is specific. If it is negative, that means it is normal or just 1 or 2 times the upper normal limit, then it is called negative. Negative test rules out the disease. That is called sensitivity. Everywhere it is the same. Sensitivity means if it is negative, it rules out the disease. Specificity means if it is positive, it confirms the disease. Positive in disease, PID. Negative in health, NIH. Sensitivity is NIH. Specificity is PID. Remember that. Now, can I do another test? Yeah, you can do late night salivary cortisol. How do I get late night salivary cortisol sample? Patient will be sleeping. How do I get a salivary sample? Either from the drooling that is happening from the patient's mouth, or there is what is called a small patch-like thing, a tissue paper, an absorbent pad-like thing is inserted into the mouth around 11 to 12 a.m. That is in the midnight, between 11 and 12, and then that is taken out with a forceps. And that is called the salivate method. And then what you do, you analyze it, and there are cutoff values. 1.45 grams above is positive, means confirmatory. If it is less than that, it is negative, it is sensitive, it rules out disease. Less than 1.45 rules out disease, sensitive. More than 1.45 nanograms confirms disease, specificity. Now, midnight serum cortisol. How do I obtain midnight cortisol? I have to admit the patient the previous day, and he will be put a catheter into the vein and a cannula, and so that he is not awake when we are taking the sample. Exactly at around 12 a.m., we draw the sample and send it for this one. If it is less than 1.8, it 100% rules out hypercorticism. It is a highly sensitive test. If it is more than 1.8 micrograms per deciliter, it is not very specific. So it cannot confirm the disease, but this test can rule out the disease. Suppose I combine the 24-hour with late night cortisol or the 24-hour with sleeping midnight cortisol. Here I can confirm the disease. Here I can rule out the disease. Sensitivity is 100%. So we will be able to find out. That is the first level of test. Supposing one of these tests is positive, better you do 2 or 3 of those tests, and at least 2 of them. If one of them is positive, then you are bound to do the second level test, which are A, B, C. That is overnight dexamethasone. You should understand how you do the test. Overnight dexamethasone test is you give 1 milligram of dexamethasone at 11 p.m. and draw the serum cortisol exactly at 8 a.m. because at 8 a.m. the peak will come. So I take an 8 a.m. cortisol, previous day 1 milligram of dexamethasone. What is the principle? When you give oral dexamethasone, what should happen? It should suppress the ACTH secretion from the pituitary, and the cortisol level should come down to less than 1.8 in a normal individual. But in an individual with hypercorticism, either from the gland or from the pituitary, the oral dexamethasone will not be able to suppress the secretion. So there will be an increase in the cortisol at 8 a.m. when we measure. If it is more than 1.8, it is 90% sensitive. More than 1.8 is specific, that is, it confirms the disease. Less than 1.8, it is 90% sensitive, means it rules out the disease. This is called ODS. How do I do? 8 milligram, 1 milligrams of dexamethasone is given at 11 p.m. as tablet. Next morning, 8 a.m. cortisol is taken and measured. More than 1.8, it is highly specific and confirms the disease. Less than 1.8, it is highly sensitive. It rules out the disease. The principle is the dexamethasone that you give from outside should suppress the HPA axis. If that is not occurring, means either there is excess cortisol ACTH coming from the pituitary, or the adrenal de novo is secreting excess cortisol by itself. One of the two things is happening. That is why the HPA axis is not suppressed. What is the other method? I can do a low dose dexamethasone. That is, give for 2 days, every 6 hourly, 0.5 milligrams of dexamethasone. That means per day I would have given 2 milligrams for 2 days. That is 4 milligrams I would have given, and measure the cortisol 6 hours after the last dose. Okay, this is people who are more than 40. Less than 40, they adjust the dose like that. This is called LDDS, standard 2-day low dose dexamethasone suppression test. The principle is same as the above. Instead of giving full 1 milligram and trying to take it, take the sample next morning, here I give 0.5 milligrams of dexamethasone every 6 hourly for 2 days, which means I would have given 2 milligrams on the first day and 2 milligrams on the second day. Total 4 milligrams is given, and 6 hours at the end of last dose of dexamethasone I take it, and it is a very same as specificity and sensitivity are same for LDDS and ODS. Both you can do. So overnight is simpler. LDDS requires 2 days of treatment. So you can try any one of them. And finally, LDDS corticotrophin releasing hormone test. Same like the above test you do, but 2 hours of the last dose of dexamethasone, we are now injecting CRH. What is CRH? Corticotrophin releasing hormone. This should stimulate the pituitary. If at all the pituitary is, if it is ectopic, it will not stimulate. If it is not ectopic, it will stimulate the pituitary. So that is to differentiate ectopic from the non-ectopic. We do a LDDS along with the CRH. The cutoff value is again 1.4 picograms per deciliter. You would have understood this. There are 2 levels of test. First level of test, 24-hour urinary free cortisol. Second level and second test, late night salivary cortisol with a salivate sample method or the drooling method, or sleeping midnight serum cortisol with a pre-inserted catheter exactly dry at 12 a.m. These tests are very sensitive and very specific, except the sleeping midnight cortisol. If any one of these 2 tests, 3 tests is positive, then you require to do another test, which is not the same test which we have done, which should be from the list below. Overnight dexamethasone suppression, or 2-day low dose dexamethasone suppression test, or LDDS with cortisone, CRH at the end of the last dexamethasone dose. 2 hours after that, you give CRH 60 micrograms usually we given. You have 60 kilogram body weight or 1 microgram per kilogram body weight, and then measure the serum cortisol not after 6 hours, but immediately 15 minutes after CRH level. So these are the tests that we have understood. Now, go ahead.
Initial evaluation requires the determination of either urinary free cortisol, late night salivary cortisol, or overnight dexamethasone suppression, or low dose dexamethasone suppression. In patient with a high index of clinical suspicion and an equivocal, discordant, or negative initial test result, the subsequent evaluation of either midnight serum cortisol level or low dose dexamethasone suppression corticotropin releasing hormone stimulation test is required. In case of an initial positive result, repeating the test and carrying out other tests increases the overall specificity and thereby decreasing the chance of misdiagnosis.
So what we are saying is take any one of the first level of tests. What are the first level of tests? Urine free cortisol, ODS, or LDDS and ODS are second level tests. You can as well do UFC, or you can do salivary cortisol, late night salivary cortisol, or you can do a blood cortisol exactly at 12 p.m. And if necessary, you can do ODS or LDS. Usually, in practice, we will reserve them for the second level. So first, if one of these tests is positive, then that is what is discordant, what is equivocal, what is negative. Discordant means one test is showing one direction, another test is showing another direction. Equivocal is not exactly going above the cutoff value, but around the cutoff value is equivocal. Negative means it is on the negative side of the cutoff, like 1.4 or 1.8 or 3 times upper normal, whatever you are saying. On the lower side of that is the negative result. 3 types of results can occur when you do 2 or 3 tests. One is discordant, one test is showing positive, the other test is showing negative. Equivocal means they are just borderline, neither this side or that side, or negative. Then what you do? Subsequently, you do a midnight serum cortisol level or LDDH with CRH stimulation may be required. Or ODS and LDDS also can be done if you have not done as a first level of test. Now, in case of an initial positive result, it is imperative that you do a second test. And the second test should be other than the primary test. You can repeat the primary test. Suppose you did UFC, repeat the UFC along with a second test, either ODS or LDDS with CRH. This is to reduce the false positive diagnosis. False positive is very dangerous because it requires you to evaluate the pituitary, evaluate the chest and other things for ectopic, evaluate the adrenal, lot of MRIs, CTs, and so much of hassle is there. So false diagnosis is always dangerous. Okay. Now, this
Cushing
summarizes
syndrome,
in a way what we have discussed till now.
Cushing syndrome is suspected. First, exclude exogenous glucocorticoid exposure. Then you have to establish endogenous glucocorticoid by 24-hour urine-free cortisol or overnight dexamethasone suppression test or low-dose dexamethasone suppression test or late-night salivary cortisol. If any test is abnormal, perform 1 or 2 other tests or repeat the abnormal test. If it is abnormal, Cushing syndrome is likely. If it is discordant, that is one test is positive and in other test it is negative or it is equivocal, then we will do midnight cortisol or low dose dexamethasone suppression with corticotropin releasing hormone test. If the initial tests are normal, even though we have high clinical suspicion, we can do midnight cortisol or low dose dexamethasone suppression with CRH test. In case of low clinical suspicion, Cushing syndrome is unlikely.
Okay. So this is very clear. The patient has got clinical symptoms and signs of Cushing's. As you have seen, body fat, skin, hypertension, weight, height, and all that list you remember. And then you suspect. Once you suspect, exclude exogenous glucocorticoid exposure because iatrogenic exogenous used either prescribed with a doctor inadvertently for a long time or patient was continuing the drug without our knowledge. It's also possible. Exclude that. Then you do better 24-hour urine UFC, 2 samples always you have to do, and then or you do a late night salivary cortisol, also 2 samples, or you can do the second level of test, ODS or LDDS. My preference is do 24-hour USP or late night salivary cortisol as the primary test, and it is very simpler test. And if one of them is positive, one of them is abnormal, then we have to perform the same test once again, along with a confirmatory test, the other type of test, like ODS or LDDS, we can do. If the second test is also abnormal, then Cushing syndrome is likely. If the results are discordant, one test is positive, one test is negative, or the results are around the cutoff value, equivocal, then you are forced to do a CRH stimulation test. You do the same LDDS with the CRH given 2 hours after the last dose of low dose dexamethasone of 0.5 milligrams. 6th hourly we have given. And after CRH, 15 minutes later, you take the blood sample. How much CRH I give? 1 microgram per kilogram body weight. That is the test. Supposing the initial tests are normal, but you still have high clinical suspicion. That's what you do. You do a midnight cortisol or LDDS with CRH. So midnight cortisol is a very sensitive test, but it's not a specific test. That is why we are not using midnight cortisol so much, but the salivary cortisol is better. So LDDS with CRH stimulation you do, and then diagnosis can be Cushing's, can be unlikely depending on the result of that second test. Supposing low clinical suspicion, the initial two tests are normal. We have taken 2 samples, 2 types of tests, they are normal. There is clinical suspicion is very low. You can say Cushing's is unlikely. Maybe follow them up after 6 months for symptoms as well as retesting. This is the algorithm. Okay. Now let us look at the next slide.
In step 3, we will determine the source of endogenous hypercortisolism. That is ACTH independent or ACTH dependent Cushing's. We have to first differentiate between ACH independent and ACH dependent. For that, we have to do basal plasma ACTH with a 2-site immunometric assay is a useful parameter for the diagnosis of adrenal Cushing syndrome. Patient with suppressed morning plasma ACTH, if it is less than 5 picograms per ml, patient needs adrenal imaging and the problem lies with the adrenal gland. If it is normal or elevated ACTH, that is more than 15 picograms per milliliter, it is suggestive of ACTH dependent Cushing's. The problem is either pituitary or ectopic ACTH. If plasma ACTH values are between 5 to 15 picograms per milliliter, these results are taken as equivocal and we have to do further investigations.
Yeah. Now, once we have established endogenous hypercorticism and excluded the exogenous administration, now the job is who is at fault? Is the pituitary at fault, or is it the ectopic secretion or the adrenal gland? Now, how do I do that? I look at the basal plasma ACTH. Basal plasma ACTH is the early morning ACTH. We take ACTH level, basal level, you take the ACTH, and there is an immunometric assay, you do that, and then this ACTH normally is between 5 to 15 picograms per ml. That is an equivocal test. So when the pituitary is secreting excess ACTH, we are bound to have more ACTH in the blood. That is 15 picograms per ml or more, which is nothing but a pituitary-induced ACTH-dependent CH. If it is ectopic, it will be even more, 30 picograms or something like that. Pituitary one will be comparatively lower ACTH level, of course more than 15 picograms, whereas ectopic one, it is not under any HPA axis. It goes on secreting irresponsibly the ectopic ACTH, and it will be more than 30 picograms also. So depending on the level of ACTH itself, you can surmise whether it is ectopic or pituitary. Most common cause is pituitary. If you have established the diagnosis of hypercorticism as in the previous slide, it will be 80%, 75%, it will be pituitary. The next test is ACTH, basal ACTH. If it is more than 15, yeah, I am dealing not with the adrenal problem, but with a problem from either pituitary or from the ectopic. So in case of adrenal disease, what will happen? Adrenal gland is secreting excess of cortisol. This excess cortisol, by a feedback inhibition, will reduce the ACTH. So I say the ACTH will be much lower than the normal value. That is less than 5 picograms. Then that means it's an adrenal disease. You do an adrenal MRI and find out it is a benign adenoma. Mostly it is, and sometimes carcinoma, adrenal carcinoma, adenocortical carcinoma, are rare diseases which are not under the purview of general medicine. So this is the next step, determining the source of excess hypercortisolism in the body, endogenous. Okay.
In case of equivocal results of ACTH, that is between 5 to 15 picograms per ml, we'll do baseline CRH stimulation test, and this test can help to delineate the source in equivocal cases. That is when plasma ACTH peak levels of less than 30 picograms per ml after corticotropin releasing hormone. This test excludes the presence of an ACTH dependent hypercortisolism.
Yeah, if the results are not very clear, that is if the ACTH is 5 to 15, what I will do, I will give them the CRH stimulation. Normally, what should happen? CRH should go there and stimulate the pituitary and produce more ACTH. So, if the normal axis is there, but if the pituitary is on itself producing more ACTH, then CRH is already suppressed, and additional CRH is not going to increase the ACTH. So ACTH peak levels are less than 30 after the corticotropin releasing hormone test, which excludes the presence of ACTH dependent hypercorticism. So what we get is, if it is ACTH dependent hypercorticism, my CRH will act further on the pituitary, and then already it is hypersecreting, and the value will be more than 30 picograms. This is to differentiate in equivocal cases. If it is basal itself is more than 50, you don't require a CRH stimulation test. Now,
next step is to differentiate between Cushing's disease versus ectopic Cushing's syndrome. Normally, by history, if females with moderate hypercortisolism, mildly elevated plasma ACTH, and normokalemia, it points towards Cushing disease. In contrast, males presenting with severe hypercortisolism, markedly elevated plasma ACTH, and hypokalemia are more likely to have an occult ectopic ACTH secreting tumor.
Yeah, this is what exactly. We know that ectopic one will produce more ACTH. So ACTH values will be 30, 40 picograms. Second thing is, if male-female distribution is same in the ectopic one, so male may be presenting as the patient here, or there may be having hypokalemia, and then bone changes also may be there in these people. In females with a mild, moderate level of hypercortisolism, mildly elevated, that is 15 to 30 picograms, ACTH, potassium is normal, more likely it is Cushing's disease from the pituitary. If it is a man with a severe hypercorticism, markedly elevated plasma ACTH beyond 30 picograms, hypokalemia, and more likely it is an ectopic ACTH secreting tumor. However, we have to evaluate both the pituitary and the ectopic source when we find ACTH dependent Cushing syndrome.
Magnetic resonance imaging of the pituitary region is the next step. There is an emerging data that the spoil gradient recalled acquisition technique, that is GRE sequence, is superior to the conventional dynamic contrast spin echo, because the GRE sequence is having a superior soft tissue contrast compared to the T1 weighted spin echo technique, and the reported rate of visualization of primary microadenums on MRI ranges from 50 to 70%, and the 30% remain undetermined. If MRI results are negative or equivocal, further tests are required.
Okay. Now, the next step is most likely the pituitary. So I do an MRI of the pituitary. MRI can detect up to 70%, and the best special technique, spoil gradient recalled acquisition technique, can be used for a better than the conventional test of the MRI. And by doing that, I may be getting around 50 to 60% confirmation. But in some patients, it is still not confirmatory, and MRI may not pick up a small adenoma. Then what do? I do petrosal sinus sampling test. So petrosal sinus is directly draining the blood from the pituitary. So the ACTH levels will be maximum in the petrosal sinus compared to the blood. If I do a petrosal sinus sampling of the blood and compare with the peripheral ACTH, if it is pituitary, even though I could not detect an adenoma by the MRI, if it is 3 times compared to the peripheral one, the petrosal sample, then I can confirm, yeah, it is from the pituitary and not ectopic. Understand? When you do that. Okay. Now, inferior petrosal sinus sampling, it is called. Okay.
In case of negative or equivocal results of MRI, initially we will do high dose dexamethasone suppression test, and the CRS stimulation test and vasopressin stimulation test have been used in the past to differentiate Cushing disease from ectopic Cushing syndrome, but none of the tests reach specificity of 90%. The only test which performs well is CRH stimulated bilateral inferior petrosal sinus sampling test. That is, a pituitary is to peripheral ACTH gradient of more than 3 is suggestive of pituitary origin, and the specificity is 97%.
Its confirmatory value is 97% for this test. Earlier, we were using several things like CRH stimulation, vasopressin stimulation, high dose dexamethasone suppression in such cases which are of no value now. If at all I have an equivocal result like in the MRI is not able to pick up the thing and I still feel it is pituitary, how do I get it? I do an inferior pituitary sampling. We have a bilateral CRH stimulated, of course. So you give a little 1 microgram of CRH and we expect the ACTH level to be more in the pituitary sinus sampling compared to the peripheral, at least a gradient of more than 3. It suggests, yeah, it is coming from the pituitary and it is being stimulated by the hypothalamic hormone. Here it is the CRH. So CRH stimulated IPSS is the confirmatory test when the MRI cannot pick up a pituitary adenoma as the cause of ACTH dependent hypercorticism of pituitary origin. Now,
but in India, IPC, inferior pectoral sinus sampling is reserved for the patient with normal imaging of pituitary, neck, chest, and abdomen, and hence prior to IPSS, a CT scan of the neck, chest, and abdomen is performed to rule out an obvious ectopic tumor. If the results of IPSS are negative, then extensive imaging such as MRI, CT scan, and nuclear scans are indicated to locate an ectopic source.
Neuroendocrine tumors, carcinoids, and others. Now, there are two ways of doing it. Supposing the MRI did not pick up, maybe it is not the pituitary is the culprit. Maybe there is an ectopic ACTH secretion from the lung or somewhere. Let me do a sort of chest and abdomen and neck CT and find out whether there is any disease. If that is also not found, ectopic unlikely, pituitary imaging could not detect an angioma, adenoma, then I resort to IPSS. IPSS is a little tricky procedure. Not everybody is equipped to do that, not trained to do that. And that is why this test in India is not commonly used, except in higher centers like where I am working. So you do a pituitary MRI, MRI negative, do a chest, neck, and abdomen CT to rule out ectopic, and still there is no ectopic is found, you still suspect pituitary as the culprit, then you do an IPSS. So if IPSS is still negative, then definitely it is ectopic. Then I have to do all out, doing a PET scan, nuclear scan, CT scan, MRI of the whole body to locate where exactly is the ectopic. Because they are treatable. If the ectopic one tumor is found out and it is a treatable tumor, you remove it, the whole issue is solved. So if the IPSS is negative and the basic CT scan test, CT neck and CT abdomen are negative, then it warrants for higher imaging tests and nuclear scanning for pheochromocytoma, pancreatic tumors, and thymus tumors, neuroendocrine tumors, bronchial tumors, medullary carcinoma, and all the other things. Okay.
Third step in is to differentiate adrenocorticotropic hormone independent cases with different etiologies. A CT scan of the adrenal gland can phenotype the adrenal lesion as benign, that is adenoma, and malignant carcinomas, depending on the lipid content and contrast washed out characters.
Yeah.
Primary pigmented nodular adrenal disease and McCune-Albright syndrome are unique causes of childhood Cushing's syndrome.
Yeah. So you don't have to worry about the last line there, because one, it is in children. Second thing is a very rare, less than 1%. So if at all you are in the group of adrenal related Cushing's, that is, ACTH independent Cushing's, that means primarily the adrenal gland itself is secreting more cortisol, not because of ectopic ACTH, not because of pituitary origin ACTH, not because of exogenous steroid. It is adrenocorticotropic hormone independent CS. Immediately we do a CT of the adrenal gland, and it can easily differentiate between a benign adenoma, which is more common, malignant for less than 1%, adenoma around 5 to 10%. And how to differentiate? The lipid content of the image and the contrast washout character. We can differentiate between adenoma and carcinoma. A qualified radiologist will be able to say, yeah, this looks like an adenoma, or this looks like a malignant tumor. The treatment is simple. If it is adenoma, then knock off the adenoma. And if it is malignant, then of course the treatment will be different.
The classical paradoxical rise in cortisol after low-dose dexamethasone suppression test is a feature of primary pigmented nodular adrenal disease. And ACTH independent macronodular adrenal hyperplasia is a rare familial disorder in which adrenal steroidogenesis is driven by non-ACTH peptides like vasopressin, glucose-dependent intestinal peptides, catecholamines, and luteinizing hormone, etc.
Yeah, I am not interested in this slide because I told you for 2 reasons. Now you go.
This is the algorithm for management of the patient with suspected Cushing's syndrome. First is clinical suspicion and screening. So clinical suspicion of Cushing's is by the discriminatory characters and non-discriminatory characters. Discriminatory characters such as proximal myopathy, livid striae, and central adiposity, and linear growth reduction in children. And the non-discriminatory such as impaired glucose tolerance and hypertension and osteoporosis in young. We have to screen and confirm the diagnosis, that is establishing the endogenous hypercortisolism. We have to establish by excluding exogenous source by asking history of any steroid abuse, and we will screen the patients, and later we will establish the hypercortisolism by 24-hour urinary free cortisol or dexamethasone overnight suppression test or midnight plasma cortisol or low dose dexamethasone suppression test. If any test is positive, we have to differentiate now between ACTH dependent Cushing's and ACTH independent Cushing. If it is ACTH is normal or high, that is more than 15 picogram per ml, we will take it as ACTH dependent Cushing's. In ACTH dependent Cushing's, we further divided into pituitary origin or ectopic source. We will differentiate between the pituitary and ectopic source by MRI pituitary gland. In case of macroadenoma that is more than 1 centimeter, we'll find the lesions in MRI. But as in whereas microadenomas, we cannot find the lesions in MRI. Then if MRI is positive or suggestive, then we'll label it as Cushing disease. If it is equivocal or negative, we will do inferior petrosal sinus sampling test. That is petrosal to peripheral ACTH ratio is more than 2 at baseline and more than 3 at after 2 to 5 minutes of CRH. We will consider it as positive. And we have to rule out the ACTH independent Cushing's by we'll do CT imaging of adrenal gland, and CT imaging can differentiate the benign cause and malignant cause.
Correct. This is algorithm from the Harrison. So very good. The same thing what we have discussed. In general, very simple. What you do is, first of all, suspicion of the clinical disease. Second thing is exclude the exogenous steroid use. Then can do a screening test. Screening test can be 24-hour urinary free cortisol, or midnight plasma cortisol or midnight salivary cortisol. Some people can employ in the low dose dexamethasone test. If necessary, you can use a sort of low dose dexamethasone test for 2 days, or single shot overnight dexamethasone test. ODS can be used. Any one of these tests, at least 2 tests we do. If both of them are the negative, then don't worry. If it is positive, then we have the bonus to differentiate. Is it ACTH dependent or non-ACTH dependent? Look at the ACTH. If it is more than 15, yeah, it is ACTH dependent. If it is less than 5, it is an ACTH independent. If it is ACTH independent, it could be an adenoma or it could be a carcinoma. Do renal imaging, CT scan of the adrenal, not the renal, adrenal imaging, and you have a benign nodular disease or a malignant disease, and work it up and then treat it. If the ACTH is more than 15, in fact, if it is more than 30, and you have male sort of patient presenting, and you have all the hypokalemia and all the other features of an ectopic 1, then you suspect that. However, you do an MRI of the pituitary first. Macroadenomas are detectable, microadenomas are not detectable. If they are not detectable, you have 2 options. Either you rule out ectopic and come back here, or you go ahead with inferior petrosal sinus sampling and establish it is pituitary or non-pituitary. the difference between the petrosal sinus sample and the peripheral sample is more than 3, then it establishes pituitary origin. Treatment is transsphenoidal pituitary gland surgery. Cushing's disease is established. And CRH test and high-dose dexamethasone test also can be done to confirm the disease. If the disease is results are equivocal, of course, you do inferior petrosal sinus sample. If you find CRH test and high-dose dexamethasone test are negative, that means it is not coming from the pituitary, it is from the ectopic ACTH production. However, you rule out pituitary by doing the inferior petrosal sinus, then that is negative. Then you locate by doing various tests like MRI, nuclear tests, PET scans to locate and remove the ectopic source. Okay. So if that is also negative, then probably bilateral adrenalectomy will be the treatment. Very nicely summarized. I want to share a few more slides, few more pages. Here, I think this is the last one, is it?
Yes, sir.
Yeah, I remember it is the last one. Yeah, this is from Davidson. Okay. Now you can see here the adrenal central part. You can see the adrenal. I just make the tools also available to me. This one is the adrenal gland. As you have seen, the adrenal gland has got a medulla, adrenal medulla, in the center, and the adrenal cortex. Adrenal cortex has got zona glomerulosa, zona fasciculata, and zona reticular. Zona glomerulosa is the mineralocorticoid secreting. It is under the renin ACA angiotensin, zona glomerulosa, aldosterone stimulation, mineralocorticoid receptors in the juxtaglomerular apparatus. All the story is about the aldosterone. That we will see sometime later. And then when you come to this side, the zona glomerulosa, fasciculata, and reticular is. The fasciculata is about the cortex, the purple color, and the reticularis is about the blue color, which is about the androgen receptors and all the secondary sex characters and libido and all that. And cortex, zona fasciculata, and zona fasciculata cortex, the cortisol, glucocorticoid receptors, and all the protein catabolism, insulin resistance, negative feedback to the pituitary and the hypothalamus, controlled by the ACTH. Okay. Now there is a specific inhibition for the ACTH part of this one, whereas there is no direct inhibition of the zona reticularis from the adrenal cortex, but the inhibition is coming from the target organs. That is a different story there. And now you see there is another beautiful slide page in this particular book, which is very easy for all of you to understand. Many a time you are confused about the various steroids. I cannot find a better diagram than representing. So how steroid synthesis can be a question in the biochemistry for the first years. Steroid hormone synthesis. Cholesterol, pregnenolone is the first thing that happens from cholesterol. Pregnenolone has to be converted into progesterone by 3-beta HSD. Okay, the dehydroxy 3-beta HSD converts to progesterone. Progesterone 21-hydroxylase, 11-deoxycortisone, 11-beta hydroxylase, corticosterone, which is a glucocorticoid. Then there is an aldosterone synthetase, mineralocorticoid. This is a line of synthesis of mineralocorticoid. Cholesterol, pregnenolone, 3-beta HSD, progesterone, 21-hydroxylase, 11-hydroxycorticosterone, and then 11-beta hydroxylase, corticosterone, aldosterone synthesis, aldosterone. Okay. Instead of going in this direction, let us say the pregnenolone is converted by 17-hydroxylase into 17-hydroxypregnenolone. Then this will go, the same hormone will make it into, instead of progesterone, it will be 17-hydroxyprogesterone. Instead of 11-deoxycortisone, it will be 11-deoxycortisol. And 11-beta hydroxylation will lead to cortisol. This is the primary glucocorticoid. The purple color is glucocorticoid. The orange color is aldosterone. Now, let us say the 17-hydroxypregnenolone is further acted by 17-20 liase. then dihydroxyepiandrosterone is produced. And from then the beta hydroxylation is same, androstenedione, then there is, from here the reaction is different. 17 beta HST again comes here, and 17 beta HST leads to testosterone, 5 alpha reductase leads to dihydroxytestosterone. Instead of being acted by the 17 beta hydroxy directly, the aldosterone, if it is acted by the aromatase and also by the 17 beta hydroxy, you end up with estrogen in the first level, and that converted into estradiol. These are the female sex hormones. These are the male sex hormones. This is the glucocorticoid. This is the aldosterone. A very, very easy way of remembering steroid hormone synthesis in the adrenal gland. And the deficiency of what hormone causes what, you can easily surmise from this particular chart. Remember, this is Davidson in page number 667. I don't know what edition it is, and in that book, you can browse and look at that.
Okay.
And now I have got another share. Okay, this share is about here only, Harrison's principles of internal medicine. The same thing in such a complicated way is represented here. Whatever you have seen, the same diagram with all those rings and all is so confusing, which we'll never understand. This you have already projected in this one, this also you have projected. Very nice. This is important for the control of the angiotensin part of it. And then you have the adrenal cortex cell receptors, a very micro sort of, at the micro level, corticosteroid target cells, how they act, and also the kidney distal convoluted tubules and adrenal zona glomerulosa cells, how they act. And now this table you have shown, this one 75%, 15% are ACTH dependent, 75% are Cushing's disease, 15% are ectopic ACTH, and then 10% are ACTH independent, out of which most of them are adrenal adenomas, and only a small proportion are the adrenal carcinomas. But you have shown this symptom chart also you have shown, very important, these two charts from Harrison, and also what I wanted to show here is this is the libido reticularis, or the libido, the livid striae, which you see, and the easy bruising, and then the striae there in this one. First one is central obesity, broad purple stretch marks on the abdomen, and the close-up of that is B. This is on the abdomen, and C is this one. This one is the thin and brittle skin in the elderly patients with Cushing's syndrome and hyperpigmentation of the knuckles in ectopic adrenocortic ACTH syndrome. Hyperpigmentation also occurs in metabolic syndrome, and this is in individuals. You can see a very dark knuckles and dark metacarpophalangeal joints. And this slide you have shown, this you have taken from Harrison, very beautiful. I think this is good enough for us to do it, and I suggest all of you to do what? To just write notes of what you have learned. And the two articles which I gave you, I'm going to share with the group also. They can also read the two articles, particularly the first article is very interesting, from where you have taken most of the materials. So hope you all understood.